Let's do it.
Hello, and welcome to another episode of Fertility Docs Uncensored. I am Dr. Carrie Bedient at the Fertility Center of Las Vegas, and I am joined by my two sumptuously lovely, stunning co-hosts, Dr. Susan Hudson from Texas Fertility Center.
Hello.
And Dr. Abby Eblen from Nashville Fertility Center.
Hey, guys.
How you girls doing?
We are
Doing
good.
great. Hanging in there.
So we all get an occasion to dress up for together. And this will probably be
So excited about this.
Yes, this will be one of our girliest chit chats ever, I think. Okay, so what are you gonna wear?
You first, Susan.
I'm going first. Okay, so I'm actually reusing a dress that I bought probably almost 10 years ago.
Wow, and you can still wear it. That's awesome.
Well, it's one of those dresses that it's a long, full length dress with like the poofy skirt and the tulle under the skirt and all that jazz. And it's kind of champagne pink colored. And then over it, it has like this kind of gauzy layer, and it has little silver and gold swiggles. I don't know how else to describe it. But the back of it is like a drawstring type of thing, kind of like a corset. So it's as little or as big as you want it to be. So
fortunately for you, Susan, you're tiny, so you really don't need to use the drawstring. Some of us might need to use the drawstring, but I think for you, you'll be fine.
Just because I'm saying this on the podcast, the real reason I wanted to make sure was like, do I really have to get another bra to wear underneath this, or can I just cinch it tight enough?
Stitch it up. I know all the undergarments, like, you got to make sure that this doesn't poke out and that doesn't poke out,
So
the stuff poking out and the stuff poking in, both are equally problematic in different ways.
I'm all about dresses that like come with all equipment provided.
Yes. Yeah.
How
about yours, Abby?
So I'm kind of between a couple of dresses, but mine also, you'd mentioned sequins. Mine will have lots of sequins. So I'm kind of like, do I want to do that many sequins? But, it's like, you don't get to really dress up like this very often. So, when you have an opportunity to wear sequins, I think you should take advantage of it personally.
I mean, it's black tie or Mardi Gras formal. And
that's true. It is Mardi Gras. So Mardi Gras bright color. That's a good idea, Carrie. That makes me want to wear my royal blue sequin dress then. So yeah, that's a good idea.
What are you doing, Carrie?
So I just ordered a bunch of stuff off Amazon because I don't think I own a long dress right now because I have no reason, because I am a nerd who does not go anywhere. And so because it is
But you have a sperm and an egg dress.
I do have a sperm and egg dress, but that is not fancy enough. Like if I was going to do a sperm and an egg dress, I would have to like sew the sequins on.
See, you should put some sequins on the sperms and the eggs. There you go.
If I had more time, I would seriously entertain such an idea. But I ended up looking for, the search criteria was like green sequin dresses. And so there's like 3 or 4 really deep, pretty green color dresses that are on their way. And so we'll see if they fit. Who knows? I may show up in a shopping bag, to be determined.
The challenge for me was with my height. When you're only 5 feet tall, you have to make sure they're petite or they're not going to work. So that was my challenge. I was limited to like the 3 places that had petite formal gowns. But the one
only 5 foot tall.
Yeah, Susan, I'm only 5 foot tall. What are you talking about? I'm only 5 foot tall. I'm a shrimp. I'm a squatty shrimp.
At least you're 5 foot tall. I mean, it's positive.
Yeah,
I mean, I have to say my mom was 5'3", and my first goal in life was to be taller than
your mom. Yeah.
Like that was really the first goal that I ever remember.
Somehow I got gypped in the tall jeans because neither my mom nor my dad were that tall, but they were both taller than me. And it's not supposed to work that way. I'm supposed to be in between my mom and dad, and I wasn't. So yeah, I kind of got gypped on the jeans there, but oh well,
All right. What questions? Because we have no shortage of questions.
Okay. So our first one is hello from Italy. And thank you so much for our listeners over in Europe. We appreciate that, and everywhere else overseas. What is COVID's effect on sperm and egg quality within the 3 months leading up to egg retrieval in ICSI? We recently had some people who were knowingly sick expose themselves to us, and my husband just tested positive. So far, I'm still negative. I will be 39 soon. PCOS, controlled Hashimoto's, lean insulin resistance, AMH 11.5, estradiol 44, FSH 4.7, had right tubal patency a little over a year ago. We're supposed to do egg retrieval, ICSI, very soon. If I remain negative, even though my husband had COVID, is it still possible to continue with our date this winter, or is it better to postpone? Considering my age, is the quality of eggs more important than the sperm? Grazie mille.
Ooh,
And my apologies if I totally mispronounced
blew that.
the Italian.
What do you think, Abby?
So I don't really know. We typically let patients go through, even if their husband had COVID, just like everything else in life, we don't really know a bunch about COVID and how it impacts things. We know that when you get pregnant, sometimes if you get it early in pregnancy, it can affect your placenta and placental flow. But I don't know that there's a lot of great data on sperm and on egg. I think as long as you don't get it, I don't really think there's a huge impact on you. I think if you're actively infected, certainly, or have recently been actively infected, I think you probably should wait, a couple of months to kind of get your system back to normal again. But I think in your situation right now, you're probably okay. What do you think?
I'm going to kind of break this down. In the sperm factor, I think I'm more concerned about if he has a high fever, obviously affecting sperm function, production, availability. And just like Abby said, there's not a lot of published data about this. A lot of this is just kind of what our experience has been over the past 3 years. I would say that if you have had COVID in the past 3 months, I would wait. I had a couple of people who early on in COVID maybe didn't completely share the entire truth that they had COVID recently and things like that. And they ended up having some poor retrievals that were unexpected, or cycles that I even canceled because they weren't responding the way that I would have expected with somebody with good ovarian reserve. And it was like, oh, well, I had COVID. Do you think that would play a factor into it? So I would generally recommend kind of the 3-month wait for that. And then when it comes to embryo transfer, I generally ask people to wait 90 days from when they test positive to do an embryo transfer. So less concerned about the guy, unless he had a high fever. But if you end up having it, I would wait, because IVF's expensive, and you want to make, and even if you're not having to pay for it, and either it's paid by insurance or either by the government or whatever, I would, you only want to do it as few times as possible. It's a hard process to go through, and we want to make every time we do it worth your efforts. What do you think, Carrie?
So COVID has been found in sperm, typically not after people have been recovered, but it's definitely been found. And I want to say there was one study that showed that by the time you hit 3 months, you were clear. Another one that said for 6 months for guys. And so I think it can have an impact. Now, again, I think high fevers make a difference because that's going to dramatically decrease numbers. I think if his sperm count or sperm quality is questionable to begin with, then I would probably push a little bit harder to wait longer until he's at least 3 months out, if not 6. When you're starting to factor in age like that, waiting 6 months seems like an eternity and then some. And so, but I think 3 months is a little bit more reasonable. I've had the same kind of anecdotal experiences that Susan has had, where somebody came in after the fact and said, oh, I had COVID, after we watched them unexpectedly tank a cycle. And we try and wait, if someone's had COVID, for anywhere from 6 to 12 weeks, depending on how severe it is, before we do a retrieval from the time that they're fully recovered. And so, I think it's a best judgment. I think if he has COVID and he's gotten pretty sick, I would try and wait a couple months. Most of the work is being done by the egg and all the machinery within the egg, but the sperm's still important too. We need a nice package of DNA to pass along to help make that embryo. So yeah.
All right, let's do one more. Hi, love your podcast. I'm grateful for the advice. I'm 37 with regular, albeit painful, 28 to 30-day cycles. AMH4 corresponding AFC greater than 10. Sperm testing was normal. Last year, I had a pelvic MRI for evaluation of an invasive fibroid, which was removed. On that MRI, a 2-centimeter endometrioma was noted on my right ovary. This was also seen on multiple ultrasounds since during 2 failed IUIs this year. My REI suggests that I leave it alone as we are moving on to IVF, and it is indeed an endometrioma. It should not inhibit successful pregnancy via IVF. Meanwhile, the fertility community has relayed that such degree of endometriosis may impact retrieval and particularly transfer, and suggest a push for lap plus excision. I'd love to hear your expert opinion. That's a great question.
Well, that is a great question. That's a really insightful question because you really highlighted kind of 2 different populations of people in our field. When I started out, 20 years ago, we laparoscoped everybody. If you had a 2-centimeter endometrioma back then, we'd be taking it out before you do IVF, and probably would have scoped you even before you started to IVF and gotten rid of any endometriosis. And so back then we got rid of endometriosis. We worry now, you're right. Some people worry that having endometriosis can make the endometrium less receptive. And so there is a little bit of a kind of a, well, what do we do? I think most of us pretty much agree that probably a 2-centimeter endometrioma, and even bigger than that sometimes, is really not worth the risk of damage to your eggs. So when we go in surgically, we have to cut through normal ovarian tissue. We have to pull out the endometrioma, and we use cautery. And when we do that, that can damage the ovary, can damage egg cells, and we don't replace those. So I think most in our community would say probably you should not have surgery. You shouldn't have anybody go in. 2-centimeter endometrioma is not all that big, and sometimes they're even hard to find when they're that size. So I definitely wouldn't go in for that size endometrioma. What I would say is once you have eggs, and maybe before you transfer embryos, what you might want to consider doing is doing a receptiva assay. That kind of looks at BCL6, which basically is an inflammatory marker that can present when you do have endometriosis. If that's positive, then you may consider laparoscopy, some sort of removal at that time, or you may want to consider treatment with Lupron, which is less invasive. And that's also been shown to help get rid of that inflammatory marker. So yeah, you bring up a really interesting point that a lot of people don't think about. There's sort of a yin and a yang when it comes to endometriosis in terms of what to do.
What are your thoughts, Carrie?
I think 2 centimeters is probably not big enough to merit going in and taking it out and cutting into the ovary. I would definitely agree with that. The main way that I think about when does an endometrioma need to come out before IVF versus after versus not is if it is causing you significant pain, get it out. If it is impairing the ability to get those eggs out, like physically blocking them, then yes, that's more complex and that probably needs to come out. But if you otherwise have the ability to get to those ovaries, a lot of times we want to leave it in place. We know that we do need to have slightly stronger doses of medications to overcome the local hormonal influence, but going in to cut it out the concept is great. The functionality of it is far lower than what you think it is because you're going to damage your ovarian tissue by doing that. And especially for just a 2-centimeter endometrioma, that's nothing. You can overcome that with Lupron. I would even say you may not necessarily need to have a receptiva because you already know the answer. Like you already know that you've got endometriosis. So just treat with the Lupron and go forward.
Or Orlissa.
Or Orlissa. It's always nice to take a pill as opposed to poke yourself in the butt.
Yes.
All
Good
right.
stuff.
So what we are talking about today is what does a normal menstrual cycle tell you? And so Abby, why don't you start with what are the normals for a menstrual cycle?
So normals in terms of timing, and this is a question I ask every single new patient, how many days from one period to the next? Because that really kind of gives you a sense for whether or not an egg is really being produced. Because when an egg is produced, usually the window of time after the egg is released is about, 14 days, give or take a little bit. And so, if you release an egg at the right time, then you should either be pregnant or have a period about 2 weeks later. And so timing, we want to make sure that your cycle's pretty normal in length. We want to make sure that you don't skip months, because if you go usually more than, give or take, about 34 days or more, you're maybe having a period, but it's not because you've ovulated. And so it's really important to make sure that your cycles are the right length. On the flip side, if they're really short, like maybe less than 24 days or so, then again, we worry that maybe you're having periods, but you're not ovulating, and that's not what's causing your period to occur.
And can really short periods also make us, when I think of length of periods, I would say 26 to 34 days pretty normal. And I would like to mention that also it's okay if, you normally have maybe 31-day periods, and then occasionally you have a 27-day period. That variability is normal among the human race. And so, we often have
stress and anxiety and all.
I had an early period, or I had a late period, plus or minus, a few days. And it's like, it's okay. It's okay. That's normal. I know it may not be normal for you, but it truly is normal. And so when we think about people who have periods that are, say, every 35 plus days, those are people I'm more concerned about that may not be ovulating on a regular basis, if at all. Whereas people who have shorter periods, so people who have 21, 23, 24-day cycles, those are people I'm usually more concerned about maybe having diminished ovarian reserve. So their ovaries may be acting older than their stated age.
Okay. So let's talk about all of the labels for a minute, because a period is brought about by a fully functioning system, right? So you need the pituitary, which is the organ in the brain, to give instructions. You need the ovaries to respond, the uterus to respond, and an open tract in order to let everything flow through. And so when we're describing periods, technically, and in the journals, and when we're trying to really nail things down, there's a couple of different labels that we use. And there's one set of labels that we use when we're describing the ovarian part of it, and one set of labels that we're describing using when we're describing the uterine part of it. And so, Abby, what are the labels for the ovarian sets of descriptions? If you're going to divide the cycle into half, the front half and a back half, what do people talk about?
Okay, I'm just going to interrupt here because both Abby and I have like funny looks on our faces for those of you who are following us on YouTube. And trust me, we both know the menstrual cycle, and neither of us really have any clue what Abby.
You can't read your mind. Give us a hint.
What Carrie's wanting us to tell her.
Okay, so thinking about if you have follicular development in the ovary, it is the blank phase versus
follicular phase. So the two phases of the menstrual cycle are follicular phase and luteal phase. That's what Carrie is looking for. Okay, we just couldn't read her mind, but
when it comes to the uterus, she's talking about the proliferative, which is the first half, and the secretory, which is the second half.
There you go. All right.
And so part of the reason I bring that up is that most people in our world don't go walking around talking about the follicular phase or the secretory phase or whatever, but there are a lot of people who talk about the luteal phase.
Yes.
And so when we're looking at that, what's the difference between the follicular phase and the luteal phase when you're talking about the ovaries?
Well, the one thing I would say about the follicular phase, we do talk about that, or I do talk about that with patients, because a lot of times when patients don't secrete the right hormone from the brain, the FSH from the brain, a lot of times the eggs just stay stationary. They don't go anywhere. So we typically see that a lot of times in patients with polycystic ovary syndrome, because they produce FSH, but they don't produce it kind of at the right time to grow the eggs and make them get bigger. So in the follicular phase, FSH is really important. And typically, once we get out of the follicular phase, then we get into the luteal phase. And the hormone that's the most important there is progesterone. And so progesterone is something that we really worry about if you don't get enough of that, or if you don't make enough of that hormone.
So, Carrie, what I'd like to do is kind of start at the beginning and kind of talk through what happens actually in the menstrual cycle, so that we can get some clarity for some of our listeners, because I think we may be throwing out some terms that everybody's heard, but we're not sure how it all fits together. So at the beginning of a cycle, your brain, the pituitary, is going to produce a hormone called FSH. Okay. And that's one of the hormones that we test usually on day 3 of the menstrual cycle. So it should be low, and then it's going to rise. And that FSH is going to talk to the ovary. And it's going to tell the ovary to produce little cells within the follicles, those little fluid-filled sacs that we're watching on your ultrasound, to produce little cells called granulosa cells. Those granulosa cells produce estrogen. And then the estrogen will rise. And as it rises, the follicle gets bigger and bigger. And when the estrogen level gets to around 180 to 200 as a general ballpark, it is going to send the message back to the brain that the brain and the pituitary needs to send out the other hormone that we talk about, LH, okay? And that LH is then going to talk back to the ovary and say it's time to ovulate. And when it gets that message, a tiny little hole is created in the follicle. The ovary contracts, and that's the reason why sometimes people have pain when they ovulate. It's something called Mittelschmerz. It's actually the ovary contracting. So there is actually a reason that you could have discomfort. And you release an egg into the pelvis. Now, that egg is ideally going to be picked up by the fimbriae of the fallopian tube. And then it starts.
So one quick thing I like to point out here is the egg, it's not like it just goes poof and the egg comes out.
Yes.
It can be over a 24 to 48 hour time frame, because a lot of patients will say, well, can I come in and make sure my egg has been released? And it's like, well, it's really not that simple. A lot of times we can't obviously see that your egg has been released. So it's kind of a slow window there. It's not like it just goes poof and it's gone at that point.
Exactly. Now, after ovulation, what happens is that follicle that you ovulated from goes through this magical conformational change and becomes something called a corpus luteum. Okay. And that in your ovary starts producing progesterone. And over the kind of approximately 2 weeks between ovulation and when you would normally start your period, if you get pregnant and pregnancy hormone or HCG starts to be produced within your body, then the corpus luteum keeps producing progesterone. However, if the corpus luteum doesn't receive that HCG message, it will involute or collapse. The progesterone level will drop, and that is what makes you have a period. Now, interestingly enough, also, for those of you who are potentially going through embryo transfers and you're getting estrogen and then progesterone, sometimes people ask us, hey, can you measure my lining after I start my progesterone? Well, when we have that progesterone exposure, we've been watching your lining get thick. Actually, when we give you progesterone, your endometrium contracts or shrinks, which is normal in preparation for the kind of architecture it needs to help maintain a pregnancy. So
and if you look at that microscopically, you would actually see mucus come out. So that's kind of why it shrinks down, is because those little cells start to secrete mucus and it shrivels up and thins out a little bit. So that's the menstrual cycle in a nutshell.
It really is. So when you have someone who flat out misses a period, what does that usually mean that is or is not happening?
It means that they're probably not growing an egg. Either their egg is just stationary, or it's just for whatever reason they don't have eggs. But for some reason their egg is not developing, because it means that, like I said before, if once the egg starts to grow and starts to develop and it's released, 2 weeks later you either have a period or you're pregnant. And so if that doesn't happen, that suggests that the egg really never developed the way it was supposed to.
Another thing that can happen, if you're a person who normally does have menstrual periods and all of a sudden you miss a period, there are a few things that can be. So 1, you could be pregnant. Yay. Okay. 2, which is something we often see, is that you may have a follicle that you were supposed to ovulate from that may be still producing hormones, whether it's estrogen or progesterone, and it hasn't gone away in the timely fashion that it should. Okay, those can be reasons why. And then other things that are a little more rare, but we still see them very commonly enough that we all test for them, is it could be sign that you may have something else going on, like an issue with your thyroid or your prolactin level, both hormones produced by your brain that if they're off, they can mess up good, healthy follicular recruitment and ovulation.
So what is going on if instead of flat out missing a period, it's just really long in between them? Like you have periods, but they're every 40 days or every 50 days or something like that. What is being lengthened? What's going on there?
Sometimes we can see that as a result of some sort of stress. So it can be physical stress, it can be psychological stress. And it's kind of things happen on a continuum. So your cycle goes 28 days, and then sometimes if you're exercising too much or you're not eating enough calories, sometimes your body sees that drain in energy, and so your cycles start to get longer and longer, and eventually you just stop ovulating altogether. So it can happen along a continuum, and it can be related to the things that you do, and also stressors that you have, that you're exposed to as well.
So another thing that can cause it, especially in people who are chronically not ovulating on a regular basis, is as kind of a society, we call a period anytime you have vaginal bleeding. Okay. Now, the truth of the matter is, I consider a period something that's the result of that really long thing that I just described a few minutes ago, an organized, hormonally controlled shedding of the lining of the uterus. Now, the thing is if you don't ovulate on a regular basis, that doesn't mean that you don't have any type of estrogen exposure in your body. Okay. And any type of estrogen exposure, whether it's from your ovary or from fat tissue or from foods you may eat or different things like that, it's going to build up the lining of the uterus. Now, it's not going to build up a lining that's as architecturally stable as what you would have during a regular ovulatory cycle. And at some point, essentially, it's a giant Jenga puzzle. It's going to fall apart. And so when people have anovulatory bleeding, meaning bleeding that happens in cycles that you're not ovulating, essentially the lining of your uterus is just kind of breaking off because the Jenga puzzle fell apart. And so it's the best your body can do at the moment to try to clean house. But again, people who have this anovulatory bleeding, because it's not the good spring cleaning we need to have every month, those people are going to be at increased risk of getting things like polyps or little overgrowth of the lining of the uterus.
So when someone has a really short period, like let's say they're running 21 days or so, what might be going on there? Like why might it be a shorter interval than the classic 28 days?
Well, Susan mentioned earlier, sometimes in older patients, we tend to see that follicles are recruited a little quicker. So eggs are recruited a little quicker, and everything just gets shorter in that cycle. It can also be from anovulatory bleeding too. And kind of like Susan was saying, what happens if the lining builds up and it doesn't really have a good directive in terms of when to release, it kind of does it at different times. And sometimes it can do it shorter intervals, because if the lining gets really thick and outgrows its blood supply, then you slough it off basically.
Okay, so let's talk about the actual bleeding within a period, because there's period, which is the time that someone's actually bleeding, and then there's the period which we kind of think of in the more abstract, which is the 28-day cycle and how things are going up and down. So, how long should the bleeding part of a period be usually?
I would say 3 to 5 days is a pretty typical time frame. I mean, everybody's a little bit different, and how heavy it is a little bit different. But I think for the average patient, it's about 3 to 5 days.
Yeah, I'd probably extend that maybe a little bit longer. A lot of it has to do with like, what does your period start with? What does it end with? We consider first day of full flow as day one. Some people have some spotting that goes on beforehand. Some people have some things that kind of linger on. Um, you
But I
know,
think normal, though, most people don't linger before and after. Most people sort of have it in a window of time. I would think the average person has it sort of in that window.
yeah, I would say 3 to 5 days, maybe a little bit short. I don't know, Carrie.
I think when you look at the textbook definition, it goes up to about 7 days.
Yeah.
But the definition of what kind of bleeding they're having in that is, there's a big range for that. You know, when we have people describe bleeding to us, or when we're trying to get somebody to tell us how much bleeding they're having, we typically go by, you know, how many pads do you soak in an hour? And clarification in that is really helpful. Like when you're telling your doctor, I'm soaking through a pad an hour, there's a huge difference between a panty liner versus one of those adult maxi,
Right. Yeah. Makes a
huge
big
pads that
difference.
can hold your entire blood volume and then some. And so knowing what kind of pad and knowing what fully soaked is. I mean, there are some people who they see any blood and that counts as soaked, versus others where it literally cannot hold another drop. So, you know, when it comes to quantification, those are some of the things that we look for. But why do some people have really, really heavy periods?
So some people can have heavy periods because of sort of pathologic conditions. There's a condition called adenomyosis where the lining of the uterine cavity grows kind of in the wall of the muscle. And for whatever reason, that can cause a lot of pain. It can cause a lot of bleeding. If you have extra overgrowth of the endometrium, like we talked about before, either from not having regular cycles and just buildup of the lining, or sometimes even precancerous conditions can cause that as well. So hyperplasia with or without abnormal cells can make you have heavy bleeding as well.
So I'd say the people who have the heavy bleeding that I see most often are going to be people who have the polyps, the overgrowth of the lining of the uterus, which are very, very common. If you have irregular periods or you're overweight, they're even more common than the average person. If you have fibroids, other kinds of benign growths or safe growths of in the uterus, those can make you have heavy bleeding. And sometimes if you have even a thyroid disorder, that can make you have heavy bleeding. And sometimes people even have blood clotting disorders. We don't see those nearly as often. Those are usually diagnosed before they come to see us, because they're the, teenagers who are having like crazy heavy bleeding and really anemic and those types of things. Something called von Willebrand's disorder is probably the most classic disorder that we think of, but those are all things that can play into really heavy bleeding.
Well, one thing I would say, if you truly have anemia and there's no other cause for it other than your heavy periods, no matter how long your period lasts, or regardless of what we're saying, if you have anemia, that's pretty significant. So you certainly need to let your doctor, work that up, and you need to make sure that you take iron and things like that to build up your blood count.
Mm-hmm. Other abnormalities of shape can impact people's bleeding. Sometimes people who have really big septums, they don't shed the lining as efficiently. And so they end up having really clotty periods. Same with people who are having heavy bleeding for any reason. If that blood is allowed to sit there, it will coagulate and form a clot. And then when those clots pass, number one, they tend to hurt more because they still have to go through that tiny little cervical hole, and that pushing that through is the same kind of motion of pushing a baby through. It's the contracting muscle going through a space that is smaller than what needs to pass through it. And then so that can cause a lot of pain, and then it also freaks people out because they see, oh my gosh, I have all these huge clots, and it's just because there's not a real efficient way that the uterus is getting rid of it. On the flip side, so what causes really light periods? The kinds that are like panty liners for 2-3 days and that's it, or maybe one heavy day and then they just lighten up. What can cause those kinds of periods?
So there can be hormonal causes. So, for example, I mentioned this before, people who exercise a lot, they can stop having periods, and their lining can get really thin, and they just kind of stop having periods altogether. Um, Things like thyroid disorders on the flip side, if they're hyperthyroid, sometimes they can have frequent but really light periods. And then if they've ever had any kind of surgical procedure, and this would be more something that would be, it wouldn't be just something that would come out of the blue, but if you've had a surgical procedure, and not just one DNC, but if you've had several DNCs, sometimes that can thin your lining out. Sometimes it can even cause scarring in the lining that absolutely makes you stop having a period altogether. So if it's linked with any kind of surgical procedure, then that's something that you should think about.
the surgery procedures I tend to worry most about are if you've had a baby in the past and maybe you had a retained placenta and they had to go and do a surgical procedure after you delivered your baby. Those are generally the surgical procedures that are aggressive enough that may cause that. You can also get scarring in the uterus if you've had things like tuberculosis. That it's rare for you to get that, but that is a possibility. And then also, even if you're taking certain fertility medications, so if you are taking Clomid, especially month after month, and if you're noticing your periods are getting lighter and lighter and lighter, Clomid itself can cause your lining to get thin, which may actually kind of hurt your chances. So sometimes changing your medications to other things like either letrozole or injectable medications might make your uterus a little more hospitable of an environment.
People who've had procedures complicated by infection, so even just a simple DNC by itself most of the time is not terribly aggressive. It's done just to get rid of whatever the immediate concern at hand is, whether that's heavy bleeding or polyps or miscarriage or whatnot. But if it's complicated by an infection, that can cause scar tissue in much greater levels. Also, what we kind of see is over time, as women get older and their egg quality starts to diminish, a lot of the times their periods will get shorter and lighter as well, because instead of making a ton of estrogen from this really robust egg, they're making far less. And so when there's less estrogen, the lining of the uterus is not quite as thick. When the lining of the uterus is not quite as thick, there's not as much to come out. And so you get maybe one day of bleeding and then a little bit of spotting for the next day or two, and then it's gone. And so that can be a very normal evolution of people's periods as well. All right. Are there any other burning period questions that we need to answer today? And I mean that on an urgent way, not your period's burning, because I feel like that's a totally separate episode.
Well, the thing I picked up about this talk today was from now on, instead of saying period, I think I'm going to say organized hormonal shedding of the uterine lining. I'm going to take that from Susan. That's like a conscious uncoupling, like Gwyneth Paltrow and her conscious uncoupling. It's an organized hormonal shedding of the uterine lining. I like that.
There's a difference. There's a difference. Just because you're having bleeding out your vagina, it's not a period necessarily.
I think you should put that on a t-shirt.
I know. So if you don't have regular periods and we are giving you medicine like Provera or Prometrium or medroxyprogesterone acetate or something like that.
Progesterone in some form.
In some form. Essentially what we're doing is we are building up that progesterone level and then taking it away. So you have that drop in progesterone to make you have that organized shedding of the lining of the uterus to clean house so we can make room for a baby.
Well, and one other point I want to make, and I had this conversation with somebody today in the office. A lot of people think, and even today, people think, oh, if I don't have a period, but once every 6 months, it's okay as long as I have a period. It's not okay. You need to have a period at least every month because, like Susan said, it's really important and it's really healthy for you to slough your lining off. You don't want to go for months at a time without having a period because over time, those are the people that are at high risk for things like endometrial cancer or cancer of the lining of the uterus. So you really need to make sure whether you're in the baby making phase of your life or you're not, you need to be on something to make yourself have a period every month. That's the healthiest for you and for your uterus.
And the caveat to that is that you need to be having a period regularly unless you are very intentionally doing something that will not give you a period regularly. So for example, if you're on birth control pills,
that's okay.
and you take them 3 months back to back and you get a period once every 3 months or once every 6 months, that's fine because you are hormonally protecting your uterus. That is a very different thing than someone who gets 2 periods a year and they have no progesterone exposure, because that's where you start to open yourself up to cancerous and precancerous problems. And so there's a huge difference between not doing anything to prevent periods and they're not coming versus actively managing your periods with birth control pills, whatever, IUD, Depo, whatever it may be, and not getting a period. Those are two very, very different scenarios.
Agreed.
Okay. All right. I'm trying to stall here. Any other last minute just burning thoughts that the American public needs to know about their period?
I think we have
think we did.
covered
Okay.
the
I think we've
big
got
red
it.
issue.
Excellent. Well, to our audience, thank you so much for listening. Be sure to tune in next week for more. Be sure to subscribe, leave us a review in Apple Podcasts. We'd love to hear from you. We're on Instagram, we're on Facebook, we're on YouTube. Stop by, say hello, give us a like, leave us a funny joke, all the things.
You can also visit us on fertility.suncensored.com to submit specific questions, and all questions will be answered on the podcast anonymously for our Ask the Doc segment. Leave us episode ideas, but don't hold back. We'd love to hear from you.
As always, this podcast is intended for entertainment and is not a substitute for medical advice from your own physician. All right, we'll talk to you soon. Bye.
Bye.
Bye.